So immunotherapy is approved for platinum refractory patients, and there are 5 immunotherapy drugs which are approved. But pembrolizumab was the only drug which has level 1 evidence backed by the phase 3 Keynote 045 trial. So that is our drug of choice for patients who progress after platinum-based chemotherapy, although any of the other immunotherapy agents can be used too. And as far as first line immunotherapy use goes, only patients who are not eligible for cisplatin and have a high PD-L1 expression in their tumors, or patients who do not have high PD-L1 expression are recommended to get single agent immunotherapy, pembrolizumab or atezolizumab. These are the only 2 agents recommended. And patients who are not eligible to receive carboplatin either, they can get single agent immunotherapy too. And we really don't have a strict definition for patients who cannot get carboplatin, but our group had done a consensus survey last year and presented at GUASCO some guiding factors to which patients cannot be recommended carboplatin. But there's still a lot of work to do, identify those patients.
Currently, there are 5 checkpoint inhibitors that are approved for metastatic urothelial cancers. And in this space, most of them and all of them are really approved in the second line therapy and beyond. So this includes pembrolizumab, nivolumab, durvalumab, which are all PD-1 inhibitors, whereas PD-L1 inhibitors are avelumab and atezolizumab. In terms of how the PD-L1 expression levels would factor in these FDA approvals, it is important to recognize and remember that these 5 checkpoint inhibitors that are approved for second-line therapy and beyond does not really rely on the PD-L1 expression. So that means if a patient has failed prior chemotherapy, for instance, and they are eligible because they have progressed, they can go on to any one of these 5 checkpoint inhibitors. On the other hand, there is one disease state that is limited by PD-L1 testing, and that is in the first-line metastatic urothelial cancer setting in terms of the cisplatin-ineligible patients. And you may all recall that in 2018, the FDA set the limit to the use of pembrolizumab and atezolizumab, especially for patients who are considered cis-ineligible. So the value of PD-L1 testing is limited largely to this population of patients with a cis-ineligible first-line metastatic setting. And that is because the key findings from the Data Safety Monitoring Board that showed that the key phase 3 trials of IMvigor 130 and Keynote 361 showed that the monotherapy arm of the atezolizumab and pembrolizumab respectively actually showed decreased survival compared to the platinum-based chemotherapy arm. So in essence, if we are thinking of a patient who is cis-ineligible, PD-L1 testing would be beneficial because if they have high expression of PD-L1, that's the time when we can use this over chemotherapy. Obviously, if they are considered platinum ineligible, meaning they cannot receive carboplatin, then that would be the time that you can use these drugs without really testing. Now, my view is, for the longest time in the history of the treatment landscape of metastatic urothelial cancers, unfortunately, we've had a dearth of drugs. We've only had chemotherapy for the longest time. And we know that since the use of checkpoint inhibitors and when they came out in the market, it has really truly revolutionized treatment. Now, the challenge we face in the bladder cancer community is that the actual responses with the use of this drug still, has to be improved. It's in the order of 20-some%, sometimes as much as 40-some% in those who are PD-L1 positive. So it's still a big area of increased unmet need. So, and one other thing to consider is while most patients do tolerate it without any issues, it is not fully without toxicity either. So these have to be factored in when considering, patients for these types of treatments with checkpoint inhibitors.
So the drugs are fairly well tolerated compared to chemotherapy. Most patients really do very well. Quality of life is tremendously maintained on immunotherapy compared to chemotherapy use. However, the risk of immune-related adverse events needs to be explained to the patients because even though rare, some of these adverse events can be fatal. So we do really good teaching and monitor patients very closely. Now that pembrolizumab dosing has been approved for every 6 weeks, we still do every 3-week checks on the patients to make sure we're not missing anything, because the immunotherapy related side effects can be quite subtle compared to what patients observe with chemotherapy.